Welcome to Smilow Shares to NET awareness, highlighting awareness in diagnosis and treatment for patients with neuroendocrine tumors. We are really happy to have you here this evening, and I'm excited to talk a little bit about advances in the field, and then we'll open it up for a Q&A, and we will certainly be done by 8:30. I'd love to introduce my colleagues who will be joining us this evening. So just to introduce myself, I'm Pamela Kunz. I'm an associate professor of medicine and medical oncology. I'm the director of the Center for GI Cancers, and I co-lead the neuroendocrine tumor program. I'll be giving a talk on just NET 101, just some basics on terminology and a brief overview of medical treatments. My colleague, Dr. Gabriela Spilberg, is an assistant professor of radiology and nuclear medicine. She is the leader of the Theranostics program, and I'm certain that she'll be talking about that. And she will be talking about NET imaging and theranostics. Dr. John Kunstman is an assistant professor of surgery and a surgical oncologist and co-leader of the NET program with me. He'll be talking about surgical approaches to NETs. And Dr. Silvio Inzucchi is a professor of medicine and endocrinology and the clinical chief for endocrinology, medical director of the Yale Diabetes Center, and program director for the fellowship, and he'll be talking about the intersection of NETs and endocrinology. So I want to acknowledge why we're doing this around November 10th. So we're one day early, but NET Cancer Awareness Day is November 10th around the world. In 2021, this was acknowledged as a formal day in the state of Connecticut by Governor Ned Lamont. And this was really due to the advocacy of the Carcinoid Cancer Foundation and their advocacy. So I will move on. We're going to each try to talk for about 15 minutes. This will be really a rapid overview, but please feel free to put your questions in the Q&A. We can try to answer some of them as we go, and I may pull out some of those and we can answer them live. So I'm going to go briefly over just some history and epidemiology, talk about the language of neuroendocrine tumors, which is like learning a foreign language, and then a brief overview of treatment. So originally, neuroendocrine tumors were actually called carcinoid tumors, or carcinoid, which is a German word coined in 1907 by a German pathologist, Dr. Oberndorfer. And he coined this term in the early 1900s to describe cancer, and it meant cancer-like. We now, in fact, know that these are, in fact, cancers and can grow and spread. Neuroendocrine tumors can start throughout the body. Certain primary sites is where they originate, and it's most commonly in the GI tract and the lungs. They are derived from neuroendocrine cells in the gut and elsewhere. That's why they get their name. Neuro meaning sort of nerve stimuli kind of signal to these cells, and endocrine because some of them can secrete hormones. And most grow slowly in comparison with their adenocarcinoma counterparts, which is the more common kind of GI and lung cancers. And a receptor called the somatostatin receptor is usually present on the cell surface, and we'll be talking about a number of these themes throughout. Are NETs really that rare? Well, they are rare by incidence, meaning the number of patients diagnosed per year is quite rare. However, the prevalence, the number of patients alive with NETs, is actually quite high. So the prevalence of NETs exceeds that of stomach and pancreatic adenocarcinoma combined. That's in this figure here on the right. So neuroendocrine is in yellow, and it's much less prevalent than colon and rectal cancer. However, it is really the second most prevalent GI cancer, which is, I think, really important. And when I speak about this, it is really more of a public health problem than has been previously recognized. So this is not intended for you to read all of this, but I'd like to introduce you to a tool called NET Vitals that was developed by LACNets, which is a patient organization based in Southern California. And this is really a wonderful tool for patients to use to learn about their NET as they go into their physician appointments. And I'm going to talk a little bit about some of the key elements of this, but this is available on the website that I've listed below. So the first is really familiarizing yourself with some of the language. It's really like learning a brand new language, and I'm going to help translate some of those words for us tonight. So the first is primary site, and the second is learning if the cancer has spread and where to. So we're going to take a moment. So what does primary site mean? Well, it means where did the cancer originate? We, the physician community, used to be lumpers. We used to sort of think of all neuroendocrine tumors as being the same, and we now really realize that they are different. Nets of different primary sites have different incidence rates, different biology, respond differently to treatment, and therefore are now studied in different trials. Small intestine is the most common, followed by lung, pancreas, and then other primary sites. And a really key point is that if the neuroendocrine cancer spreads, it retains the properties of that primary site. So a common misperception is that if your neuroendocrine tumor spreads to the liver, that you also have liver cancer, when in fact, it's the neuroendocrine cancer that has spread and it retains the properties from where it originated. Again, stage, and we're not going to go through all of these components, but stage means where in your body is the cancer. Stage for a physician, we determine that by three things: the T, the N, and the M. T refers to tumor. That refers to how deep does that invade, for example, the lining of the small intestine, how big is it? N refers to lymph nodes, whether they're present or absent, and M means has it spread to distant sites. And so for example, a stage 4 would indicate that a patient would have metastases that have, for example, spread from the pancreas to the liver or spread from the pancreas to the lung, and that by definition is stage 4 or metastatic. We use, and I will not go into this a lot because I know that my colleague, Dr. Spilberg, will be talking a lot about gallium-68 dotatate PETs, but we use these to help us determine stage, really extent of disease and volume of disease, meaning how much cancer is in the body. So going from left to right, this is a picture of a gallium-68 PET scan, and it shows here in the middle a pancreatic mass that looks bright. In the middle, this is a patient with a pancreatic neuroendocrine tumor, but it has spread to the liver. All these black spots indicate liver spots. So this is liver dominant, but it's fairly bulky, so high volume in the liver. Whereas on the right, this is another scan where a patient has a small intestine neuroendocrine tumor that has spread to the bone. So all these little tiny spots are bone metastases. And this is widely metastatic, but it is low volume. So as you can see, three very different pictures, but these new gallium dotatate PETs or somatostatin receptor DOTA PETs really help us with the diagnosis. So the next is understanding your pathology. So the pathology is, what do the cancer cells look like under the microscope? This could be obtained by my colleague, Dr. Kunstman, if he does a surgery, or by other colleagues if they do a biopsy. And I would say that there are four key things that you need to learn in terms of terminology, differentiation, grade, and Ki-67. So this is another screenshot from that Net Vitals page of what to ask or what to try to learn about your cancer. So I'm going to go into the details a little bit here. So these are the four things. This table is adapted from what we call the World Health Organization classification. And the first is terminology. So neuroendocrine tumor or neuroendocrine carcinoma. So the neuroendocrine tumor are generally the slower growing, whereas neuroendocrine carcinoma or NEC are generally faster growing. Differentiation falls into two main categories: well differentiated or poorly differentiated. Well differentiated usually means that under the microscope, the cells look a lot like the normal tissue from which they originated. Whereas poorly differentiated means that the cells look quite a bit different or more disorganized compared to the normal tissue. Grade can either be used grade 1, 2, or 3, and sometimes we'll use low, intermediate, and high. And then lastly, the Ki-67, that's a marker that our pathologists help determine with the use of a special stain. And it's on a scale of 1 to 100. 100 is very fast growing and 1 is very slow growing. So as you can see, net grade 1 is a Ki-67 less than 3, NET grade 2 is 3 to 20, and NET grade 3 is greater than 20, as are the neuroendocrine carcinomas. Another really key thing that we have here down on the bottom is to request an expert pathology review. So this is something I always do for when I see new patients. I have our Yale pathologist review and do a second review on any outside biopsies, because our pathologists are also expert. So I use a number of characteristics. I'm not going to go into all of these, but to help determine how I select treatment, we have just gone over what I have described in red. So primary site, stage, volume of disease. My colleague, Dr. Spilberg, will talk a little bit more about somatostatin receptor status, grade, degree of differentiation. All of these things factor into how we select treatment. Treatment falls into 4 main categories. Dr. Spilberg will talk about peptide receptor radionuclide therapy. We often use tools called somatostatin analogs like octreotide or lanreotide. We have targeted therapies such as everolimus and sunitinib for pancreatic NETs. And we have chemotherapies. So there are some older chemotherapies. One's called streptozotocin. That's an IV chemotherapy. Captem, many of you have heard of. These are pills. Capecitabine and temozolomide, also for pancreatic NET. And then platinum etoposide are used for neuroendocrine carcinomas. And I'm really just going to touch the surface of this. NET treatments also differ by primary site. This is adapted from the National Cancer Clinical Guidelines, the NCCN guidelines, and they are a number of different algorithms for every primary site. This is just an example for pancreas and small bowel I've adapted. So we often will start with observation or octreotide or lanreotide. This is for metastatic NETs. Subsequent therapies you can see listed here. I've put in red. What's really exciting is that 2 weeks ago, we had the presentation at the European Society of Medical Oncology that a new clinical trial was positive using a medicine called cabozantinib. So we're hoping that that will get FDA approved next year. Small bowel NETs, similarly, a number of different options. So I want to, and there are patient guidelines that match these in the NCCN guidelines. So I'd highly recommend, this is a very trusted website, and highly recommend referencing that. I also want to highlight that all of our clinical advances stem from doing research and clinical trials. We have 4 NET trials open at present at Yale, hoping to get more. This first one, and you can ignore some of a lot of our clinical trials are numbered by a kind of a code number. This first row is resected, well-differentiated pancreatic NETs and giving post-operative chemotherapy, so that's Captem. The second is for patients with metastatic pancreatic NETs, and it's basically putting half the patients on Captem and half on Lutathera. And the third, I'm going to let Dr. Spilberg talk a little bit about, but it's this new form of PRRT that uses a different radioisotope called actinium-225. That's an alpha therapy. And then the fourth trial we have open is for neuroendocrine carcinomas, and it's using immunotherapy plus chemotherapy. So I'm almost done, but I really like to end on this slide. I think it is, I want to leave you with a sense of hope. In the early 1980s, we had 2 available drugs for treating metastatic NETs. And you can see for the ensuing almost 30 years, we had no FDA approvals. And starting in 2011 was just this explosion of research. On top, we have 3 imaging agents that were approved. Down on the bottom here, we have a number of therapies that were approved, and that trajectory is continuing. So I think it is a very hopeful time. And I talk about that with my patients. I think the clinical trials research that we do is very hopeful, and I'm very excited for the future in terms of drug development and new discoveries. So just to sum up, so primary site matters for treatment selection. Stage indicates where the cancer is located. Grade refers to the biology or the degree of aggressiveness. As I just showed, we've made many advances in the last 10 years in terms of treatment and imaging. And clinical trials are really critical to making progress in NET treatment and are a huge reason for hope. So I'm going to stop share. I am going to pass the baton to my colleague, Dr. Spilberg, next.
Hi, good evening. Thank you, everyone. It's a pleasure to be here tonight. It's been a year I've joined the team at Yale, and I have to say we could not have a better team together. A lot of this requires coordination between multi-specialties, and this is key into making our program work. And again, it's a very happy event to be here tonight with you all. With that, I'm going to be talking about imaging and theranostics. I have no disclosures. So when we talk about imaging, we talk about imaging in two different buckets, kind of. One is what we call anatomic or conventional imaging, which includes computed tomography, magnetic resonance imaging, ultrasound, and X-ray. And these are usually static images. They're pictures of a physical structure that allows characterization of patterns of contrast enhancement when we give contrast in the vein. And these basically, we look at the structure of an organ or a specific system. And then we have what we call molecular imaging. Molecular imaging acquires usually two data sets. One is a positron emission tomography, and the other is a computed tomography, just like in the other one we just saw. And then we join both of these together and generate this color-coded image, which is a fused map of both of them together. So when we look at these, molecular imaging really allows us to look at the processes that are happening in the body at a cellular level, which are very different when we're looking at anatomical imaging. Here we're looking at events and things that are ongoing, and then we join that with the static imaging from the CT for better anatomic localization and understanding what those mean, so we can put both of them together and understand what's happening. And here is just a normal gallium dotatate PET, where you can see this is the normal biodistribution. And then here on the other side, you can see that there's these dots. This is the liver. So these are abnormal dots in the liver. This is a disease here in the liver. And we'll go a little bit more about what these mean. Here. So what do we use on PET-CT? We don't use contrast. We use something called a radio tracer, which is a little different. A radio tracer is a compound that has a radioactive agent, which we call radionuclide, and the carrier, and this carrier has a target. In NET tumors, usually we look for somatostatin receptor type 2 as a target. So we inject this radionuclide in a peripheral vein, and it finds a target in the body. And where it finds the target, it builds up in areas that this receptor is expressed. And typically in NETs, especially grade 1, 2, and some of the grade 3, these are overly expressed. So we will see these areas of disease. So the tracer is injected in this peripheral vein. It's non-invasive and it's painless. Then we wait for about 60 minutes so that this tracer circulates throughout the body and it can find the locations where there is tumor. And that period of time we usually call the uptake time. And after this time, then we obtain the images, which we call the PET scan, which lasts maybe about 30 minutes. And this is just a picture of what the scanner looks like. And it's rounded just like an MR, but it has a CT and a PET together combined. And then we have, right now, there's 3 types of radio tracers we can use to image nets. The first 2 ones, the only difference is the radionuclide that they are attached. And there's no head-to-head comparison study showing that one is better than the other. It's really important to get timely imaging and consistent. So if you've had one before, you should always follow with the same so that you can compare apples to apples and not apples to oranges. That's very important. And then for tumors that are more aggressive, that start losing the expression of somatostatin, then these tumors we can sometimes image with FDG, which is the traditional tracer that we used to call traditional because we used to have only one, but now we have almost 10 in practice, and this is one of them, and it's the more commonly used that really looks for metabolism. So it's a surrogate for cells which are fastly replicating. Usually those are reserved for neuroendocrine carcinomas and more dedifferentiated disease. So, for example, molecular imaging has a lot of advantages. This is a CT scan in bone windows, and these look completely normal in the CT scan. However, if you look at molecular imaging with PET combined, you can see that indeed this is not normal. There is extensive disease in the bones that you cannot identify in a traditional CT. So it's very important that we understand the extension of disease. And for that, metabolic imaging is really key here. And then moving on from the imaging into theranostics. So theranostics is a bit of a buzzword. It's the junction of therapeutics plus diagnostics. And the concept is we can treat if we can see something. And we use the same molecule and we change the radionuclide. So we have a ligand which has a target. We have a linker and a radionuclide. And if we attach a diagnostic agent, then we can image with PET. But then when we find this target present and expressed, then we change this radioligand into a therapeutic ligand. In the moment we use lutetium-177, that's also known as Lutathera, is the commercial name of this drug. I'm just clarifying because sometimes it's not, it's less known for the lutetium name. But, and then we use the same molecule and we inject in a vein the same way, and this finds the tumor cells and treats it. So it's really a targeted treatment modality that is targeting in NETs the somatostatin receptor, predominantly type 2, and in a very specific fashion that we only find this overexpression in cancer cells. So it decreases the side effects of normal cells in that setting. So again, theranostics is really teamwork. It's very important that everyone is on the same page. No two patients are the same. Every single patient is unique. And even when you don't see multiple doctors, we still all meet and talk in the background. We have these things we call tumor boards, where we go over the imaging, the clinical findings, the pathology findings, and we review with a multidisciplinary team what is the best approach for each patient. And regarding imaging, it's very important to make sure that all your prior imaging is within the system. So if you've had prior imaging in other institutions, it's very important for us to have all your imaging history, because this is really key to understanding what is the behavior of the disease throughout the cycle. So how do we do this treatment, and who is eligible at the moment for that? So this is the label indication, which is for gastroenteropancreatic tumors that have spread or are locally advanced. They're inoperable and they have progressed previously with a long-acting octreotide. So we usually do 4 sessions, which are 8 weeks apart of this fixed dose. And sometimes if there is toxicity, which can be, for example, a decrease in the hemoglobin and some anemia or things like that, we can space more these sessions. So we always follow in between the cycles with labs and visits, and we follow to make sure that if there is anything to be adjusted, we take action upon that. And then the day of the treatment is an infusion. The whole day is about 6 hours. And we do an amino acid infusion to help protect the kidneys. Then we do more amino acids after the treatment itself to just complete it. This is the therapy suite that we have at Yale. And then these are specific precautions that we use after this treatment, because this is a radioactive treatment. So once we administer the treatment, there are specific precautions that are very important to follow. So this is an example of a patient that was treated. The patient, this is the first scan, this is a gallium dotatate, and you can see that there were a few lesions. And then the patient developed more lesions here in the liver. This is the liver, and these are small peritoneal nodules. And here the patient started to get treatment with lutetium-177 dotatate. And this is after the end of treatment, where you see most of the liver lesions have disappeared and the small nodules have also disappeared. Not everyone will have this impressive result here, but we're working on getting this result for more people with newer technologies. As a side note, there's a trial that recently met endpoint that was also was recruiting at Yale, so it happened here. And it met endpoint early, meaning that it demonstrated statistically significant and clinically meaningful progression-free survival, which means that lutetium compared to high-dose long-acting octreotide alone performed equivalent or better. And these results are yet not out, but they will be presented at GI ASCO in the early 2024. And based on that, it is expected that this may become a first-line therapy in the future. But this is very exciting because this is the first time that this category of treatment is brought into the front line or into the initial treatment cycle of a disease. And we have a lot of these on the work, so this is very interesting. So what do we do from here? What is the future? So right now we use beta particles, which have a lower energy, but they travel a little more. And not always they cause enough damage in the tumoral cells that kill the cells. So we're looking into alpha emitters, which are other type of radiation, which actually causes more damage to the cells, but doesn't travel as much. So we're opening this trial now called Action 1, which is dotatate linked to actinium. Actinium is the radionuclide. So these are for patients who have previously been treated with lutetium, had transient response, and then progressed again. And then we believe that with the preclinical data we have, that they will have a response to actinium. So it's very exciting time in this field. combination therapy. There's ongoing trials, and possibly we'll look at those in the future about combining this type of this modality of treatment with other medications. And then what kind of targets and what kind of binding agents do we use right now? We don't have, that's still unexplored. And then as we go into better imaging technology, there's something called total body PET, where you can acquire a whole PET CT in less than 5 minutes. So we're going from 30 to less than 5 in the near future. That's going to be even with better resolution, so we will have lower radiation required. We'll be able to maybe image everyone with FDG and somatostatin receptor imaging. So, and there are new targets being looked at for specific subsets of population. And then, as I showed before, we do 4 doses and they're standard. But there's a question if people with different disease burdens should really get different doses based on the amount of disease they have. And we still don't have enough data to say that should happen. So that's also in the works. And with that, this is what I had to share. I'm open to questions and any doubts in the end.
Thank you, Dr. Spilberg. So we will pass next to Dr. Kunstman.
Good evening.
And
Go ahead.
You can keep going.
All right. Let's see here. So tell me, are you seeing the right one or the wrong one?
You need to switch.
Hold on here. How about now?
Looks good.
All right. Good evening, everybody. I'm John Kunstman. I'm one of the surgical oncologists here at Yale, deeply involved in the neuroendocrine tumor program, which I co-lead with Dr. Kunz. And my role this evening is to talk about the surgical management of neuroendocrine tumors. So I'm going to move fairly quickly, but my goals for this portion of the evening are really, we want to talk about which patients should get surgery. I think it was already mentioned earlier that by Dr. Spilberg that really every patient has an individualized approach in neuroendocrine tumors. There's not really a single cookie cutter thing that applies to everybody. And we'll also touch briefly on patients that may be able to forego surgery or at least delay it. We'll talk about what surgical options exist for both pancreatic neuroendocrine tumors as well as enteric neuroendocrine tumors, the two ones that we most frequently see in clinical setting. And we'll kind of use small bowel neuroendocrine tumor as an example in a case study and talk briefly about surgery in the cases of metastatic neuroendocrine tumor. So Dr. Inzucchi is going to talk about this in great detail, but I just want to mention, and we're going to start by talking about pancreatic neuroendocrine tumors or PNETs. One of the main divisions we make is whether a PNET is functional, and by that I mean it secretes hormones that the pancreas normally makes. These tumors are what we call functional because the dominant hormone that they're producing can cause symptoms. And historically, most patients with PNETs were diagnosed in that manner because of those symptoms. And some could be more indolent, such as insulinomas, and others can be more aggressive. And by aggressive, I mean the potential to grow and spread. However, most of the cases that are diagnosed today are non-functional in that they don't create symptoms that patients notice from hormone hypersecretion. That being said, if the tumor is large enough, it can push on regional structures and can cause symptoms like pain or weight loss, or even jaundice that might not be directly related to hormone secretion, but are relevant in terms of selecting patients for surgery. As I alluded to before, treatment is stage specific. We'll come back to this a little bit later, but if patients do have metastatic disease or stage 4 disease where they're spread beyond the primary organ, in pancreas cases, sometimes surgery is still the right thing to do. I think the most important thing to remember is that whatever the situation is, there will be treatment options that exist, and surgery might be appropriate in some of them. For patients with non-metastatic disease, surgery is usually the primary treatment modality for pancreatic tumors. Essentially, all patients with functional PNETs that can be removed should be removed, or patients that have non-functional PNETs that might be causing some of those local symptoms like jaundice or weight loss. There are some special cases where the tumor itself might be tied up with some vascular structures, or what we call locally advanced, quote unquote, unresectable tumors. That's a word I really don't like because it's really in the eye of the beholder. And also sometimes PNETs that are associated with genetic syndromes might be special cases that alter some of those statements. But for patients with incidentally discovered neuroendocrine tumors of the pancreas, which again is something we see more and more these days, again, and I hope you're catching the theme, it's a very individualized decision. We look at a lot of different factors, some of which were alluded to by Dr. Kunz, in terms of what the aggressiveness or the potential for an indolent PNET might be. Some of those factors are listed on the screen. It's important to mention that all PNETs do have the potential to grow and spread. One thing we encounter frequently is patients may be told, like, oh, you have this neuroendocrine tumor, but it's benign. I don't really think there's a true entity of a benign pancreatic neuroendocrine tumor. There are those that are much less likely to grow, and some may be very, very unlikely to grow or spread, but certainly all do retain that ability to do so. So that begs the question, for certain PNETs that are reassuring, that might have those more indolent features, can they be observed? An early study from the Mayo group looked at this, and really in a small number of patients at a single institution, they concluded that some patients with very small disease that was observed had actually the same survival and only underwent resection if things actually got worse. Now, this was studied by other groups, first at Duke, then here at Yale, using both internal and database studies that did suggest there was a group of patients that we might be able to forego surgery on in this group. And Memorial also looked at their data too. Now there's some additional studies, but all this put together, really the conclusion to make is that some PNETs are safe to observe. Not everybody needs an operation. And that's an important thing to remember, because we find also, we see a lot of patients at Yale for second opinions, and many folks have been told you need an operation, and that's not necessarily always the case. I think it's important, as Dr. Spilberg mentioned, to have a team where these cases are reviewed. And at Yale, and I think this is recommendations that are pretty widely shared at high volume institution in terms of who would be candidates for observation with a PNET. Again, if it's non-functioning and asymptomatic, there's no evidence of regional spread or lymph node spread. We have a biopsy that suggests it's well-differentiated pathology. Again, going back to that early grade or low grade disease in the terminology Dr. Kunz discussed. It's small. We know that size is a risk factor for both regional and distant spread. And I think most importantly, and the thing that's often forgotten, is that the patient themselves has to be on board with this plan. I think one symptom that goes underreported for these tumors is anxiety. There are some folks that may qualify with those top entries on the list for observation, but they themselves are very uncomfortable with it. And they might not be amenable to follow up, or somebody that doesn't want to get scans for a repeated period of time. Those are all very valid points that aid the decision making. Again, going back to that theme of an individualized decision. When patients do go to the operating room for a pancreatic neuroendocrine tumor, my goals, and my partner's goals from an oncologic or a cancer point of view, is that we want to really get the tumor out and maximize local control. We call an R0 resection with negative margins. We want to take out the lymph nodes in that area to make sure all of the disease has been removed and we properly staged the tumor. If those are achieved, survival is improved, and especially if patients are symptomatic or have a functional tumor, the quality of life is improved. But almost as important as getting the tumor out is making sure the complications are low and any complications that do occur are well managed and recognized quickly. In the short term, for pancreatic neuroendocrine tumor resections, those usually revolve around pancreatic leak or fistula formation or infection. And in the long term, the risk of diabetes or exocrine insufficiency, while low, is certainly there and needs to be anticipated and managed well. So how do we pick a surgical approach? Well, tumor location is very important. How many lymph nodes need to be removed? Similarly important. And again, the patient's tolerance for an operation based on their performance status and other medical problems. And we'll kind of go through that in detail. So just taking operations by operation, the most, the smallest operation, I should say, in the pancreas for removing a neuroendocrine tumor is something called enucleation. That really is exactly as it's shown there in the cartoons. It essentially leaves almost all of the normal pancreas tissue behind. The tumor itself is just sort of shelled out of the pancreas. As shown in the bottom cartoon, you can see the pancreatic duct. I don't know if you can see my pointer options. If you can see my laser pointer here on the mouse, the pancreatic duct needs to be uninvolved to enucleate a tumor. Otherwise, the pancreas duct will leak. It does have a very low complication rate, and it leaves most of the normal pancreas behind. But again, the margins are very close. No lymph nodes are removed. So not every case is a good candidate for that. And that's what it looks like. And you can see for an aggressive tumor, one that's perhaps higher grade, or one that we suspect may have spread, this isn't a good operation to do. But for some patients, it would be. It's most frequently done for insulinomas. For most patients, though, enucleation is not the right choice. And as I said, the tumor location is the most important thing in sort of selecting where the operation and what type of operation is the best to do. So the pancreas anatomy, it sits in the back of the body here in a left to right configuration. And just grossly, the head is the part that's towards the patient's right side, the left side in this picture. And then the neck is what overlies these blood vessels, and then the body and the tail of the pancreas move out towards the left. And if the tumor is in the head of the pancreas, usually a Whipple procedure or pancreaticoduodenectomy is necessary, versus if it's in the left side of the pancreas, a distal pancreatectomy, either with or without a splenectomy, is usually the right operation. So a Whipple procedure is done for tumors that are in the head of the pancreas. Because of the way the blood supply to the head of the pancreas goes, some additional organs are removed that are in the direct same vascular supply as the head of the pancreas, namely the bile ducts and the duodenum, which is the very first part of the small intestine. The gallbladder is not part of that blood supply, but when the bile duct is removed and reconstructed, the gallbladder never works correctly again. So it's always removed at the same time. And in some cases, a small part of the stomach is also removed, but other cases not. The remaining pancreas, bile duct, and GI tract are all reconnected, and when patients recover, they can eat and go about their business just as they did before the surgery. Now, pancreaticoduodenectomy is an operation, or Whipple procedure, has been around for a long time. And a few years ago, I was giving a talk on the history of this procedure at Yale, and I came across this in a paper chart for a patient that had a Whipple at Yale. And you can see the date up here. This is November 28th, 1947. And actually, a current surgical resident would recognize this beautiful drawing here, actually. It was done by a prior surgical resident at Yale. The operation itself fundamentally has not changed that much. That being said, our ability to perform it successfully, efficiently, and with excellent outcomes has vastly improved. So patients sometimes ask me, is pancreatic surgery for a tumor that might be a little bit more well-behaved than most pancreas cancer, like PNET, is it safe? And in properly selected patients, yes, there's a very strong relationship with case and institution volume with pancreatic surgery. This is a very famous paper from a few years ago, and you can see on the x-axis here, it's number of pancreatic resections per year. And on this y-axis is the complication and mortality rate or death rate. You can see how it falls based on what they would consider a high volume institution. And in this particular paper, they considered a high volume institution one that performed more than 16 pancreatic cases a year. And there's a similar relationship with surgeon volume. And again, annual surgeon volume, high volume, was considered more than 4 cases a year in this particular paper. So at Yale, over the past 9 years, we've done 820 pancreatic resections. I just looked at our database the other day. That's over 90 operations per year, and currently there's 3 surgeons that do them. So you can see here our outcomes have really, really been superior, and I think it has to do with that volume and experience. When I say outcomes having improved, if we looked at death rate from this operation, the Whipple operation in the 70s, it was up to 20% of patients. Now the standard of care is less than 3%, and similar decreases in length of stay and complication rates. At Yale, we see we're better than most, and in fact in the top 10% nationally for complications, with a very short length of stay and very low mortality rate. So yes, it is safe, but it certainly has to be done in a prudent and thoughtful way. Now, distal pancreatectomy, the left side of the pancreas being removed, that's for tumors in the body or tail. There's multiple ways it can be done at Yale, and certainly in my practice, the vast majority are done in a minimally invasive fashion. Not everybody is a candidate for that, but most people are, either laparoscopic or robotic assisted. When that's done, the spleen is most often removed. Most patients with neuroendocrine tumors should have the spleen removed, namely because most of the lymph nodes in that area, if it is in the body or tail of the pancreas, exist in the splenic hilum. And there's a risk of understaging the patient if those lymph nodes are involved and the spleen is left behind. Now, we don't like taking out things we don't need to take out, but as it turns out, adults really in the modern era with our vaccination regimen, there's no clinical consequence to removing the spleen. I certainly can answer questions about that, but I'll leave it at that for the moment. Central pancreatectomy is another operation we sometimes do for neuroendocrine tumors. I'm going to leave that aside just in the interest of time. I do have a few surgical photos, so if anybody is a little bit squeamish, there's nothing too bad. I just want to give a fair warning. And so turn off your screen for a minute. But just some examples. This is a video. Let's see here. Of a distal pancreatectomy being done laparoscopically. The stomach is the part that's on the top part of the screen right now. It's being mobilized away. The pancreas is towards the bottom, and those white arrows are pointing at the tumor. The pancreas is sitting in the left to right part of the lower frame. We spend a little bit of time mobilizing the pancreas up so we can move it around and get at those tumors. And then we dissect out the blood vessels that are going to and from the spleen and the pancreas in that area. In this part, you're seeing the splenic artery being dissected out. That's the tubular thing that's being grasped. It's now being divided by a vascular stapler. The same thing is being done to the splenic vein. And then a different type of, sometimes with energy, sometimes with a stapler, the pancreas is being divided. And then the pancreas, and in this case, the spleen, is put in essentially a big sac and then brought out a small incision in the upper or lower part of the abdomen. When it's all said and done, that's what it looks like. This is a spleen-preserving distal pancreatectomy. You can see the remaining pancreas. Let me turn my pointer back on. The remaining pancreas here on the left side of the screen. In this case, again, this was a spleen-preserving procedure. The spleen is off to the right. This is the blood vessel going to and from the spleen dissected out and preserved. So in summary, for pancreatic neuroendocrine tumors, the goals of the surgery are to both control the disease and minimize the impact on people's quality of life. The operation is really driven by the location of the tumor, and the outcomes really are quite good. I want to switch gears for the last few minutes and talk about small bowel neuroendocrine tumors. Really anywhere in the GI tract, neuroendocrine tumors can arise. The most common spot we encounter them is usually in the small intestine, so that's what I'm really going to focus on. It's been the most common tumor found in the small bowel since at least the turn of the millennium. Patients usually, well, if they're going to present with symptoms, they generally present with obstruction. The tumor can cause obstruction because of mass effect or something called intussusception, where the bowel gets clogged up on itself. I have a small, very clean, non-bloody operation photo I'm just going to show you right here, where you can see there's a tumor, and this is the intestine actually invaginated like a dirty sock in on itself, if you will, if you'll pardon the analogy. And there's a tumor there that's causing that intussusception or invagination of the bowel in and on itself. Many are diagnosed incidentally. There's a very high incidence of what's called regional spread to the lymph nodes. Now, the intestine in this drawing, in this cartoon, is off to the right of the screen. And you can see the artery or the red thing that's providing the blood flow to that, but these little yellow draining areas and nodules are called lymph nodes. And there's a very high propensity of neuroendocrine tumors in the small bowel to spread to those lymph nodes. So oftentimes what will happen is a patient will get an imaging study for something and a very large lymph node will show up, whereas the primary tumor may be asymptomatic. In those patients, staging is really important. This is something both Dr. Kunz and Dr. Spilberg alluded to. The staging is very important to determine what's possible from a resection standpoint, as well as whether there's any metastatic disease or spread. Again, this is an example of a very, very small lymph node that was seen here along those blood vessels on a CAT scan. Sometimes it can be larger and more central, and sometimes it can be quite large and very central. And part of my job is figuring out what's possible to remove this disease while preserving as much bowel and function as possible. So again, our oncologic goals, we want to get rid of the disease, and we want to make sure that if somebody is having quality of life issues from obstruction or metastatic disease, we can improve that. We want to minimize the amount of bowel that's removed. And oftentimes we remove the gallbladder in these patients because some of the medical treatments can cause gallstones down the line. A few surgical photos just to finish up, quick forewarning of what that actually looks like. This multifocal tumors, you can see there are many tumors in some lengths of bowel. These are some of those lymph nodes on the right here that need to be removed in order to successfully get all of the disease out. And for that picture that I showed you before, where there's tumor involving really the central mesentery, even in case of advanced disease, oftentimes we can remove it successfully. And what that looks like with those blood vessels, the draining artery and vein completely dissected out with the bowel preserved and out of the operative field, but all the disease removed. The last thing I'll mention, I believe this is my last slide, is that in patients with metastatic disease, some are very appropriate, either bowel or pancreatic, for resection. The liver is often the site for that, but it can be other sites. In folks in whom are good candidates for that, the long-term survival can actually be quite favorable. Also, sometimes surgery plays a role simply in symptom control or palliation, but in the interest of time, I'll skip that for now. So again, in summary, really each patient individualized management. In addition to removing all of the cancer, our major goal is to maintain quality of life and minimize complications. And carefully selected patients, even with metastatic disease, can sometimes benefit from resection. So I'll end it there. These are my partners and all the folks that are involved in our research efforts. And I'll stay on for any questions at the end.
Thanks, Dr. Kunstman. Great. So we will finish up with Dr. Inzucchi, and then we'll take some questions. So I'll encourage our listeners, feel free to start putting some questions into the chat or the Q&A, and we'll get ready to answer them.
Okay, thank you very much, Dr. Kunz, and it's a pleasure to be here this evening. I hope you can see my slides okay. So I'm Silvio Inzucchi. I'm an endocrinologist, and obviously NETs or neuroendocrine tumors has the word endocrine in them, so we get involved in typically the diagnosis of these tumors, not necessarily the treatment. So I wanted to just have a few slides about what endocrinology is, who is an endocrinologist, what do we do, and then we'll look at the main hormonally active NETs. And as Dr. Kunstman alluded to, most of these neuroendocrine tumors are silent. They can present either incidentally, or they can present because of so-called mass effect, in other words, pressing or squeezing other things in the abdomen. But my main focus this evening is to talk about those tumors that produce hormones or factors that travel from the tumor and lead to symptoms in patients with certain types of NETs. So we'll separate this into the lung and gut or GI tract NETs and what's often termed carcinoid syndrome. Even though the tumors are no longer called carcinoids, we still use that tumor historically, use that terminology for the tumor that's historical. And then we'll talk about the PNETs and the specific syndromes that they make due to the hormones that they produce. So endocrinology is a specialty of internal medicine that diagnoses and treats patients with hormonal imbalances and also diseases of metabolism. Now, a hormone is a substance in the bloodstream that carries a signal or a message from one part of the body to another. So a good example of this would be the hormone insulin that is produced in the pancreas, but travels to the rest of the body to control blood glucose or blood sugar levels. Endocrine or endocrinology diseases are very simple. They're typically those that result from either too much or too little of a specific hormone. And an endocrinologist is a board-certified specialist who is trained in diagnosing and managing these patients. So these are the main endocrine glands, or the hormone-producing glands. In the brain, there is the pituitary. In the neck, the thyroid, and also adjacent to the thyroid gland would be the so-called parathyroid glands. Really have nothing to do with the thyroid, except they're situated right next door. Those are the glands that regulate calcium levels inside the body. In the abdomen, we've already talked about the pancreas, which is a very important endocrine producing gland in the back of the stomach in the upper abdomen, and also the adrenal glands, which sit on top of the kidneys. And depending on the sex, obviously ovaries and testicles in women and men respectively. So these are the conditions that we treat as endocrinologists. We treat diabetes, both type 1 and type 2. We treat patients with high cholesterol because that is a disease of metabolism. Obviously, thyroid diseases, either over or underactive conditions, tumors that involve the thyroid gland, and the same thing for the adrenal glands, the pituitary, the parathyroid glands, and certain metabolic bone diseases such as osteoporosis. And at the bottom, you'll see neuroendocrine tumors, as we've been talking about this evening. So let's talk about the endocrine system as it relates to the neuroendocrine tumors. Now, it gets a little confusing because a lot of the tumors that we see as endocrinologists, including certain cancers of the thyroid known as medullary carcinoma, parathyroid benign tumors called adenomas that lead to a condition called hyperparathyroidism, and all the pituitary hormones that we see that grow inside the brain are actually neuroendocrine tumors, but they're not necessarily lumped with the NETs that we're talking about this evening. We're talking about those that emanate from the lung, from the GI tract, and those that start in the stomach. As Dr. Kunstman mentioned, most of these start in the small intestines, as well as the appendix, as well as the large intestine. Now, these were the ones that were formerly referred to as carcinoids, but they're still responsible, if they're hormonally active, for carcinoid syndrome, and then the PNETs, as we've just heard. So the main focus would be NETs that occur in the lung, NETs that occur in the GI tract, mostly the small intestine, and then the pancreatic NETs. Now, what is carcinoid syndrome? It's a symptom complex that emanates from NETs that occur both in the lung as well as the GI tract. And the main symptoms include flushing. And very often these patients are referred to endocrinologists because flushing is often considered a hormonal type of symptom. So this would be a skin manifestation of carcinoid from NETs, sometimes diarrhea as well from the GI tract. And in terms of the main lung symptom would be shortness of breath and wheezing. And these are symptoms that occur because these neuroendocrine tumors, these NETs, actually produce a variety of hormones and peptides and other chemicals that lead to, that circulate to other parts of the body that lead to some of these symptoms as we've discussed. Carcinoid crisis is a condition where the carcinoid syndrome is very acute and severe. This can be related to very high or very low blood pressure, a very high heart rate, profound flushing, wheezing and shortness of breath, and sometimes mental status changes. And triggers for so-called carcinoid crisis in patients with hormonally active NETs include surgery or invasive procedures, a manipulation of the tumor at the time of surgery, embolization. We haven't talked about this technique, but sometimes we actually try to clot off the blood flow to these neuroendocrine tumors, and that can trigger a carcinoid crisis, stopping previously successful medical therapy for NETs, as well as just a severe stress. So this is a lengthy list of the various hormones or peptides or factors or chemicals that are produced from NETs that occur both in the lung as well as in the GI tract. And this cartoon here reminds me to tell you that the main hormone test that we measure in patients with NETs is known as 5-HIAA, or 5-hydroxyindole acid. This is typically a urine collection over a period of 24 hours, so it's a little bit cumbersome to measure, but we like it because it is a stable hormone metabolite that reflects the function of these neuroendocrine tumors that typically take an amino acid known as tryptophan from the diet and converts it ultimately to serotonin. Thanksgiving is coming, and turkey meat is very rich in tryptophan, and I think this is felt to lead to the very relaxing feeling and sleepiness that is induced after a large meal. But these neuroendocrine tumors can actually make serotonin in excess, and this can either be measured as serotonin, although that's a difficult test to measure, but we prefer measuring it in the urine as the metabolite of serotonin known as 5-HIAA. So a typical test in the evaluation of patients for carcinoid syndrome from neuroendocrine tumors include this 24-hour urine test. Also, another test that we like to use, a very stable test that reflects both the disease activity as well as the response to treatment, the so-called chromogranin A level, which is a more simple blood test, and there are a few others depending on the type of tumor. This is the flushing that we typically see in patients who have carcinoid syndrome. It typically occurs over the anterior chest, and in some circumstances, the face as well. In patients that have had carcinoid syndrome for a number of years, there can be permanent increasing in the size of the capillaries that are in the face, so you get these so-called telangiectasias, or permanent redness of the cheeks. So let's move quickly now to the PNETs. We've talked about this a little bit already this evening, but just a reminder that the pancreas is a relatively small gland that sits in back of the stomach, just adjacent to the liver, as we saw before. And interestingly, it's a dual-purpose gland. It has an exocrine component, and exocrine means that it secretes digestive juices into the intestines. And the purpose here is to break down dietary constituents such as starch and proteins and fats. But there's also an endocrine component to the pancreas. And this is the part of the pancreas that produces hormones. And these don't go into the GI tract for digestion, but they actually go into the bloodstream. An example here would be insulin that regulates blood glucose levels. And there are a few other hormones of this type as well. This is now a microscopic picture through the pancreas, and you can see that most of the pancreas is the exocrine pancreas, and this very dark purplish type of cell is producing digestive juices, and then sprinkled throughout the pancreas about 1 million of these so-called islet cells, or islets that contain individual cells that produce various hormones. One of these hormones would be insulin. So the PNETs, or the pancreatic neuroendocrine tumors, are felt to originate in these islets. So that would be the endocrine component of the pancreas, and the rest of the gland is the exocrine component. Now, there are several cell types within the islets. There are beta cells. These produce insulin, and the purpose of insulin is to lower the blood sugar, the blood glucose levels. There are alpha cells as well. These make the hormone glucagon. That does the opposite to insulin. It increases the blood sugar level. Delta cells make somatostatin. We've heard about that hormone previously this evening, and that tends to regulate both the alpha cell and the beta cell. And there are a small number of these F cells that make pancreatic polypeptide, and the purpose of pancreatic polypeptide is not well understood. Now, these neuroendocrine tumors, these PNETs, originate in each cell type, and that leads, in some circumstances, to high levels of these hormones, and that results in corresponding symptoms. Now, it's very interesting because some of these PNETs can actually make what's known as ectopic hormones, or hormones that are not normally produced in the islet cells of the pancreas. And an example here would be an antidiuretic hormone that leads to low sodium, or a hormone known as ACTH that can lead to a syndrome known as Cushing syndrome that results in weight gain and a few other symptoms. But these types of tumors can be fascinating because they can produce a variety of these hormones. And some, as we've heard already from Dr. Kunstman, are silent, they're non-functional. If they lead to symptoms, it's because of so-called mass effect. So these are the non-functional tumors. They are often associated with high pancreatic polypeptide levels. The functional PNETs result in high hormone levels, and those result in hormonal symptoms. So gastrinomas, these are from G cells that are not part of the islets, but they can occur in the pancreas, although they're usually situated in the duodenum or in the stomach. The insulin-producing cells, which can give rise to insulinomas, glucagon-producing cells giving glucaganomas, and somatostatin-producing cells leading to somatostatinomas. These three, insulinomas, glucaganomas, and somatostatinomas, are known as islet cell tumors. And the last one is a VIP-oma that actually originates in the nerve cells within the pancreas. And again, each of these tumor types result in a specific syndrome. So gastrinoma produces the hormone gastrin, and this normally gets the stomach to produce acid. So as you might imagine, if you have too much gastrin, you have too much acid, and this syndrome leads to heartburn, multiple and severe stomach ulcers, and in some circumstances, diarrhea as well. Insulin's that hormone that reduces blood glucose level. It's supposed to be controlled. You make insulin when you eat. You don't make a lot of insulin when you don't eat. But these tumors can produce these hormones in an unregulated fashion. So the insulin levels are super high, and that results in very low blood glucose. And that can lead to other symptoms such as dizziness, sweatiness, tremulousness, and in some circumstances can lead to loss of consciousness. Glucagon is a hormone that increases blood glucose. So as you might imagine, this is a recurring theme. If you have a glucagon-producing tumor or a glucagonoma, that can lead to diabetes. That can lead to high blood glucoses and a variety of other symptoms, including weight loss and diarrhea. Somatostatinomas can lead to diarrhea as well. They can lead to abdominal pain, gallstones, and diabetes. And the hormone known as VIP-omas, which is producing too much of this interesting hormone known as vasoactive intestinal peptide, can lead to diarrhea, dehydration, and very low potassium levels, something called pancreatic cholera. To diagnose gastrinomas, it's very simple. You measure a gastrin blood test. To diagnose an insulinoma, you measure an insulin level, which should be low when the blood glucose is low, but in insulinoma patients, the insulin level is paradoxically high when the blood glucose is normal. And similarly, you can check blood tests for glucagon, for VIP, as well as for somatostatin. So to summarize, the NETs can be hormonally silent, but frequently produce specific hormones that circulate in the bloodstream and lead to certain symptoms. Functional NETs, that is, those that produce these hormones, when they arise in the lung or the gut or GI tract, they cause patients to have flushing, diarrhea, and wheezing, so-called carcinoid syndrome. Functional NETs in the pancreas lead to other symptoms, and the most common ones are from too much gastrin, called gastrinomas. Those lead to stomach ulcers, and insulinomas that produce too much insulin, and that results in hypoglycemia or low blood sugar. A patient's endocrinologist and oncologist will measure the levels of these specific hormones in either the blood or the urine to make an accurate diagnosis. And of course, treating the NET itself, such as with surgery or chemotherapy, radiation, or using those somatostatin analogs, will obviously decrease the hormone levels and improve symptoms. And I would point out that in some situations, there are also specific treatments for the symptoms themselves, having nothing to do with attacking the tumor. And an example of this would be anti-acid medications for gastrinomas to prevent the stomach ulcers, and medications that increase the blood glucose levels in people with insulinoma to combat the propensity for hypoglycemia. Well, that's the end of my presentation. I very much appreciate the opportunity tonight, and thanks so much for your attention.
Great. Thank you to all of our speakers. That was a tour de force over the last hour. So we do have some questions that have started coming through. So what I might do is pose some of these to the group, and we'll kind of spread them around a little bit. I know Dr. Kunstman has to be off video, but he says he's still on audio. So we'll include him and ask some of those questions. So I'm going to go to a couple that we've answered in the chat already, but there were a few questions about scans. So Dr. Spilberg, there was a question about PET MRI versus PET CT, and then another one on sort of frequency of getting PETs. Maybe I'll let you, if you want to take the PET MRI CT, and then I'm happy to answer the second one a little bit just from the medical oncologist perspective.
Sure. So PET MRI is still a very limited technology throughout the country. So that's one of the big problems. If you get one, then you would want to follow with a similar study and not really keep switching from PET CT to MR. So given the limitations and cost constraints also, I think right now we're still not on prime time, but for younger patients who are worried about radiation doses and things like that, it's probably going to be feasible in the future as we advance technology. But at the moment, I think there's still very limited availability to make use of this technology in an optimal way.
Yeah, I totally agree. I think Dr. Spilberg had answered in writing this question about how often should a patient with a small bowel NET, and I would expand that really to any NET, get one of these DOTA PET scans. And Dr. Spilberg answered, it depends, which I totally agree. I will say that there are actually some guidelines now out on appropriate use criteria for physicians on how we make some decisions about how often to use these. Typically, as a medical oncologist, I often will be the one ordering these. Dr. Kunstman himself will also order them sometimes. And we often will get them prior to surgery to help us determine if a patient has disease that's spread outside of where we think the primary tumor is. For patients with metastatic disease, we will get them to see if they are eligible for Lutathera, the lutetium dotatate treatment. We get it to determine extent of disease. But as a routine, as Dr. Spilberg said, the main tool for imaging patients with NETs is the anatomic imaging, a CT or an MRI. We will use the PETs to answer specific questions over time in a couple of those scenarios that I mentioned. Dr. Inzucchi, I'm going to ask you a question that came up in one of the Q&A. The question is, I've heard from maternal fetal medicine that pregnancy can increase risk of all tumors. Pregnancy is related to lots of hormones. So to your knowledge, can pregnancy be a risk factor for development of a NET if a patient has not had a NET previously?
Yeah, I suspect that's a pretty rare scenario. There are a lot of growth factors that circulate in pregnancy. Most of these come from the placenta for obvious reason. The baby has to grow. So there are reported cases of patients that unfortunately had a tumor early in life and thought that they were cured and then become pregnant, and then there's a recurrence of the cancer. And it's blamed on the circulating growth factors. I've personally not seen a neuroendocrine tumor emerge during pancreas. You may have, Dr. Kunz?
I have not. I agree with you.
I think it's a relatively uncommon scenario to occur in pregnancy.
Yep, I agree. Dr. Kunstman, if you are available, there's a surgical question. Maybe I'll ask if you're available first. Yes?
Yes, yes.
Okay, excellent, good. Is there any prognostic difference for the number of lymph nodes involved at the time of diagnosis, specifically related to risk of recurrence, progression, free survival, or is it more heuristic, like fewer lymph nodes are better than more?
I think both of those statements are true. I think actually prognostically, obviously, positive lymph nodes are less favorable than negative lymph nodes. One of the things we worry about always is understaging, in that, we may remove, say, 12 lymph nodes in a particular operation, but who's to say the 13th lymph node wasn't the one that was positive, and we may not realize that. At the same time, the thing that I think is most prognostic is whether the immediate regional lymph nodes are involved. In other words, the ones, say, right next to the tumor versus distant lymph nodes that are in a separate distribution than nearby where the primary tumor arises. So I think both are true. Yes, lymph nodes have prognostic significance. More positive lymph nodes do carry a little bit more prognostic significance than fewer. But yeah, I think both are important to consider. And I would also just add that sometimes imaging does suggest that lymph nodes are involved, but oftentimes it's only after they're removed that the pathologist can tell us that they're involved.
That's exactly right. It's sometimes very hard to tell that on scans. Totally agree with you. Great, thank you for that. All right, let's see. We have a number of other questions. Here's one that came in from in the chat from Lisa Yen. Would you give somatostatin analogs to a NET patient whose dotatate scan did not light up? And maybe Dr. Spilberg and I can kind of jointly answer this. Perhaps I'll start. So this is an excellent question, and I will say, prior to having DOTA-PETs available, we would routinely use somatostatin analogs without that knowledge. So some of you may remember that prior to 2018, when DOTA-PETs were FDA approved, we had an older scan called an octreotide scan. This had much lower resolution. It was not really as reliable. And so we would routinely use somatostatin analogs without that information. I would say in this day and age, because DOTA-PET scans are much more reliable, we typically like to see presence of somatostatin receptors before considering using somatostatin analogs, and certainly before considering a therapy like lutetium dotatate. Dr. Spilberg, do you have any comments on that?
Yeah, I think NETs sometimes are very heterogeneous. So one thing that happens is, like, you can have mixed disease or disease that doesn't really express somatostatin receptor at all. And when that is the case, really the imaging really helps to kind of map that out. So for example, if you have disease that looks like it's spread but is negative on dotatate, you can get an FDG and to have a better idea of the amount of disease that you really have spread versus on anatomic imaging. So, and I think that helps you guide what therapy to use, because we're imaging the receptor expression and we will have future targets for other therapies. So as we move into that, we will be able to map real time where the disease is and what it expresses, so we can really target that in a much more in a much better way than we do today. And also, as we improve the sensitivity and specificity of the PET technology with the newer generation of scans, we also will be able to see smaller things. So sometimes very small things may not show up, but that's a resolution problem.
Thanks, Dr. Spilberg. Dr. Inzucchi, I have a question for you that has come up in the chat. So, and in fact, there's a theme of a few questions around, can neuroendocrine tumors that are non-functional become functional? So can they change and secrete hormones over time? And another question was a patient describing a situation where they had a functional tumor, but they've had tumor shrinkage and response, and their hormones have gone down. Can you just comment about the spectrum of that?
Yeah, let me take the second one first, because it's easier to answer. I do think that there's a correlation, so that if you on imaging. For instance, if Dr. Spilberg says that the tumor is shrinking, typically what that means to us, if we're following them for hormonal symptoms, is that those will, in concert with the tumor size, also abate. And that's important because we can, for instance, in a metastatic insulinoma patient, we may be using certain therapies to increase the blood glucose, including steroids, and we can back off on those treatments. The second question is, I guess, technically possible, but we think about these neuroendocrine tumors, are actually all cancers, as going in the opposite direction. So as they grow and spread, they tend to become less differentiated, meaning that they tend to behave less like normal tissue. So a more common scenario would be initially a hormonally active tumor becomes more aggressive, spreads, and loses that hormonal activity. But the question is the opposite. Do you have a tumor that is initially non-functional become functional? I imagine it's been reported. I always tell the story of a patient a number of years ago that started with an insulinoma. In other words, producing too much insulin, resulting in hypoglycemia. It was already metastatic to the liver. So we sent them for embolization, and his hypoglycemia disappeared within a day. He was having normal blood glucoses. Within a week, he started having high blood glucose. And we scratched our heads to think, did we do damage to the pancreas? What the heck is going on? And I had the thought of, let me measure glucagon level. And it was sky high. So that individual's tumor must have been a mixed type. And I think we ablated, or we damaged through the embolization procedure, the insulin producing component of the tumor, and allowing the unmasking of the glucagon produce. That's not the question, but it does underscore this heterogeneity, or mixed picture, if you will, of these tumors that can make. I gave the list of those peptides, those hormones that these carcinoids can make, but these can make a variety of peptides, only some of which we even have the lab test to measure. But they are fascinating tumors. But a long answer to a short question, but I don't think I've heard of a tumor that was initially silent and then became hormonally active. If there is, I suspect it was hormonally active all along, and it just became clinically manifest as the tumor grew. Yeah.
Yep, I agree. Dr. Kunstman, if you're available for another question, not exactly a surgical question, so I might put you on the spot, but really thinking about other liver-directed treatments. We've had a few questions come in around ablation for metastatic spots in the liver. There is a newer treatment that I think many of us don't have experience with yet called histotripsy that a question was asked about, which is a form of radiation. So Dr. Kunstman, can you talk a little bit about how we think about some of these therapies in our treatment algorithm?
Yeah, you can hear me, correct?
Yes.
Sorry, I'm just moving around. Histotripsy is actually uses sound waves, but it's a very similar concept to microwave or radio frequency ablation, in that it's a way to destroy targeted cells, tumor cells in this case, without necessarily removing them, with the goal of having less damage to the surrounding normal liver parenchyma or liver tissue. Similar concept. Some of these can be performed, actually all of those techniques I just mentioned can be performed in the operating room. There's also other techniques like irreversible electroporation or IRE that have a similar goal and mindset. They all use a slightly different physics package, for lack of a better word, to try and get around the disadvantages of needing to necessarily cut a tumor out per se. They can all be done in the operating room. Many can be done percutaneously or under image guidance in the radiology suite. Some, histotripsy has a limited ability to do this from outside the body. Anyways, I think they all are important tools in the toolbox. Histotripsy is the newest one. We actually are in talks right now to obtain a unit at Yale. We'll be one of the probably first adopters outside of the University of Michigan to use it. That being said, ultimately, these all have some drawbacks in that there's no way to verify either A, the tumor is completely removed, or B, what the adequate margin is per unit of energy delivered from whatever the technique is. So generally, the way we think about it from a liver standpoint is if it is removable, it is best to remove it. But especially in patients with multiple or widespread lesions within the liver, generally multiple modalities will be needed to get the best result. For instance, there may be some that could be removed and some in another part of the liver that can't be removed but could be successfully ablated or perhaps subjected to IRE or histotripsy. So, we really are, I'm thinking about your clinical trial slide, Dr. Kunz, we really are in a very, very exciting time in that many times in the past, talking to, senior surgeons, retired surgeons, it was so frustrating where we didn't have the ability because of some technical consideration that we can now oftentimes overcome using some of these new technologies.
Yeah, no, it is. I agree. I always talk to patients about how wanting to add as many tools to the toolbox as possible. And these are some of those tools. And there's no perfect or optimal or even known order in which we can use these. But it's really, I think, as many of our speakers have said tonight, we tailor that treatment plan to the patient. Okay,
I would maybe last comment I would make on that, just because I saw some of the comments in the question box. Ablation takes a lot of different forms. Microwave ablation is certainly the standard of care, not radiofrequency ablation anymore. And I think histotripsy will probably be better than IRE, but they all probably play a role. RF, though, has kind of fallen by the wayside.
Great, thank you. We have time for maybe one or two more questions. So I'm going to also try to cluster a few questions together, and I might take this one. So there are a number of questions that have come in around genetic testing. So genetic testing of DNA that's passed from parent to child, genetic testing of the cancer, and then there's a newer form of genetic testing where we can test for tumor DNA in the blood. So there's been a whole series of questions around these. So for cancer genetic testing, meaning testing of genes that are passed from parent to child, we generally will do that if patients are under the age of 50. And I would say especially for pancreatic NETs. So pancreatic NETs can sometimes be associated with inherited syndromes in about 10 to 15% of cases. We also take a detailed family history, and we'll talk about what cancers might run in your family. That's a blood test. And so it's actually very simple to do. And we will talk about that in oncology clinic. Many other physicians, including ones here on the call, may also talk about that with their patients, depending on the specific situation. In terms of tumor DNA testing, that has, I would say, really just, we're doing a lot more of that in the world of oncology in general. However, it's not really proven all that useful yet in neuroendocrine tumors. And that's because there aren't as many DNA changes, especially in some of the slower growing neuroendocrine tumors that we call targetable, meaning there generally is not a known drug that can target or treat some of those genetic changes. And the last question that came in is around testing DNA or tumor DNA in the blood. And again, it's not yet prime time for neuroendocrine tumors, just because we don't see a lot of tumor DNA shed into the blood. And we also don't see a lot of those genetic changes. But I suspect as we learn different ways of testing some of that tumor DNA, that we may figure out new ways to test for patients with NETs. Do any of my colleagues have comments on any of that?
I would just mention that. Oh, go ahead, Silvio.
No, go ahead, John.
I was just going to mention, there is a proprietary assay called the NET test that sometimes is used in this setting. And Pam, I don't know if you want to speak to that as well. Oh, sorry. Can you guys hear me?
We can hear you. Yeah, and I'm happy to comment on it. It's I would say not used widely, but yeah, feel free to go ahead.
But it's a similar approach in terms of looking for NET specific signatures in the blood. I think just not to editorialize, but again, I think it's a useful test, but in very, very, very specific situations. For instance, where we suspect that there's residual disease from a functional standpoint, but we cannot seem to localize or prove it on an imaging test or a functional test. Sometimes that's a useful adjunct. But again, I don't find that it's something that's helpful in a serial or continuous fashion, which is sort of how it's marketed.
Yep, agree. Silvio.
I was just going to say that one syndrome that we didn't talk about tonight, but involves an endocrinologist very commonly is multiple endocrine neoplasia syndrome, or MEN,
Yes.
specifically type 1. And pancreatic nets are common in that syndrome, but they also have tumors of other organs, such as the pituitary and such as the parathyroid gland. So that's a famous one that we've known about for years.
Yep. And that has the inherited component.
Yep.
And that certainly is when you and I partner and take care of. We have a number of patients that we take care of with that. Well, we are at time. And I really want to thank my colleagues tonight for really a great presentation. I certainly learn a lot every time I do this. I hope our audience did as well. This will be recorded and available, so we will be sure that you get the permanent link afterwards. So thank you so much for joining us tonight, and happy World Net Awareness Day. So thanks, everybody. Good night.
Bye-bye.